Structurally, the knee joint is inherently an unstable joint. It gets its stability from 4 ligaments: a medial collateral ligament, or sometimes called the tibial collateral ligament, and a lateral or fibular collateral ligament. These are both extracapsular ligaments. In other words, they're outside the boundaries of the capsule. The medial collateral ligament being one that blends with the capsule, whereas the lateral collateral actually sits clear of the capsule itself. And then inside the knee joint, we've got 2 ligaments that cross over, called the cruciate ligaments. One is anterior and one is posterior. They get their names from their attachments, from their tibial attachments. They're intracapsular, but they sit outside the boundaries of the synovial membrane. Starting off with a medial collateral ligament. The medial collateral ligament, the tibial collateral ligament, is a broad flat band. It's about as broad as three fingers, and it's around 10 centimeters long. It's multi-layered with the deep part of the medial collateral ligament blending with the capsule and blending with the medial meniscus of the knee. The lower part of the medial ligament is crossed by 3 tendons, by the tendons of semitendinosus, gracilis, and sartorius. This area is known as the paisanserine insertion, and the 3 tendons are separated from the medial ligament by a bursa, by a non-communicating bursa called the paisanserine bursa. This can become inflamed, and when it does, we can often mistake this for a medial collateral ligament injury. The attachments of the medial collateral ligament are its proximal attachment, or the femoral attachment, is that it attaches right up here to the medial epicondyle of the tibia, immediately below the adductor tubercle, and there's often fibers that continue on from the distal attachment of adductor magnus to blend into the medial collateral ligament. It passes down over here, over the medial joint line, blending with the capsule and medial meniscus before inserting down here on the medial aspect of the shaft of the tibia, as low as the level of the tibial tuberosity. So it's quite a large structure, quite a long structure and quite a broad structure in an anteroposterior direction. So palpation of the medial ligament and stressing of the medial ligament requires testing in different positions with a fairly extensive area of palpation. The function of the medial ligament is that it is taut in extension. All 4 ligaments of the knee are tight in extension, but the medial ligament will limit the movement of abduction, abduction of the tibia, so movement of the tibia away from the midline, and it also stops lateral rotation of the tibia. Consequently, injuries of the medial ligament are either forced abduction or forced lateral rotation. The lateral collateral, or the fibular collateral ligament, is a much simpler structure. It's a short, rounded cord, about 5 centimeters long. It stands clear of the capsule, so it doesn't blend with the capsule at all. And this time, it attaches to the lateral epicondyle of the tibia above the groove popliteus. It extends down here to insert onto the superior aspect of the head of the fibula, and as it does so, it passes through the tendon of biceps femoris. The biceps femoris muscle itself splits, its distal tendon splits into 2 before attaching onto the head of the fibula to allow the lateral collateral ligament through. The function of the lateral collateral ligament is to limit adduction of the tibia. It is only really taut when the knee is extended. As soon as the knee moves into flexion, as the proximal and distal attachments are approximated, the ligament goes slack. Inside the knee, we have the 2 cruciate ligaments. So here, what we see is the superior aspect of the tibia over here. This is the anterior portion. There's the tibial tuberosity. Well, this structure that we can see sectioned anteriorly is the anterior cruciate ligament. On this diagram here on the left, we have the medial aspect of the lateral condyle can be seen. So the medial femoral condyle has been sectioned and moved away. And again, here we can see the tibial attachment of the anterior cruciate passing obliquely up through the knee before attaching onto the lateral femoral condyle. It's a strong stabilizer of the knee. Its fibers pass obliquely through the knee, upwards from their tibial attachment. They pass upwards, posteriorly, and laterally. The function of the anterior cruciate ligament is to prevent anterior displacement of the tibia. It also has a role in limiting medial rotation of the tibia. Its counterpart, the posterior cruciate ligament, this is the larger of the two cruciates, and it crosses the ACL inside the knee joint. We can see again on this superior surface, on the superior surface of the tibial condyle, we can see the posterior cruciate ligament attaching to that intercondylar eminence on the posterior aspect. This time the fibers pass obliquely upwards, forwards and medially before attaching onto the lateral aspect of the medial condyle of the femur. The function of the posterior cruciate ligament is to prevent posterior displacement of the tibia. It also limits rotational movements. So medial rotation is will cause the two cruciate ligaments to wind around each other, and therefore medial rotation is controlled by the two cruciate ligaments themselves. It's important to note the obliquity of the ACL and the PCL, because it's this obliquity that leads to the locking mechanism of the knee. Tension in these ligaments, as the knee moves towards full extension, these ligaments become tight, and tension in these ligaments pulls the tibia into an externally rotated position. As mentioned earlier, both of these ligaments are found inside the boundaries of the capsule, so we can't palpate them. We can't actually get our hands on these ligaments here, because the capsule comes all the way around here, making the ligaments intracapsular. But the synovial membrane, as mentioned earlier, comes in and creates a fold around these two cruciates to keep them extrasynovial. So the ligaments themselves are not bathed in synovial fluid. The femoral and tibial condyles are inherently incongruent. There is poor congruency between the two bony articular surfaces. And to improve congruency, we have two fibrocartilaginous structures, the menisci. Again, here we can see the lateral meniscus, which is rounded, reflecting the shape of both the tibial and femoral condyles, and here we've got the medial meniscus that is a more open C, reflecting again the length and obliquity of the medial tibial and femoral condyles. They are made of fibrocartilage. They are triangular in cross section, with their thickest section being peripheral. So this section over here is the thickest portion of it. As we go towards the center of the knee, they come to the apex of their triangle, and so this is the thinnest section. Consequently, when they get injured, when they get torn, it's typically the thinner section that gets damaged. They are semilunar in shape. They are relatively avascular. They have a very small blood supply peripherally. So consequently, when they tear, especially if they tear over here in the medial, on the central side of the joint itself, they don't heal, and consequently they will require surgical excision. The functions of the menisci are simply to improve congruency between the tibia and femur. Because of their wedge shape, they deepen the concavity of the tibial surface. But due to their tissue type as well, they act as shock absorbers, and they are able to dissipate weight circumferentially due to their collagenous orientation. There is some debate as to their role in assisting with lubrication, but some texts believe, or some authors believe, that they are important for the fluid movement of the knee joint. Certainly, their most important functions is that of congruency and weight dissipation. The medial meniscus is the larger of the two. It's semilunar in shape, and it's wider posteriorly than anteriorly. Its attachments are onto the intercondylar area of the superior aspects of the tibia. So here it's attaching anterior to the ACL. Posteriorly, it's attaching posterior to the PCL here. Peripherally, the medial ligament is held down, is bound down fairly firmly via a structure called the coronary ligament, and because the medial collateral ligament blends with it, as does the capsule, it's very stable on this section here. So it's the most stable, it's the more stable of the two menisci. It is also the ligament that gets damaged most commonly in dynamic situations. The lateral meniscus, on the other hand, is the smaller of the two. It almost forms a complete circle in shape. Again, it's triangular in cross-section. Its attachments are Anteriorly, it attaches behind the ACL, and the anterior horn does. The posterior horn comes round and almost meets it, again attaching to the intercondylar eminence. Once again, peripherally it's held down by the coronary ligament, which are fibers that reflect back on the internal surface from the internal surface of the capsule to bind the edges of the meniscus down. It has no attachment due to the lateral collateral ligament or to the capsule. Consequently, it's more mobile and therefore is less susceptible to dynamic injuries, although the lateral meniscus is more prone to degenerative changes than the medial meniscus. Finally, the surface markings of the knee joint. This can be done by direct palpation of the joint line, but if the knee is grossly swollen or there is excessive tissue covering the knee, the easiest way to identify the surface marking of the knee joint is to find a line passing from the apex of the patella down to the tip of the tibial tuberosity. So apex of patella here, down to the tip of the tibial tuberosity. Bisect that line, that gives you the center of the knee joint, and draw a line that is perpendicular to the line of the tibia itself. That's where the surface. That's how we find the surface markings of the knee joint itself. So if we were to try to test for mobility of the knee joint, or try to stress the ACL and PCL, we would place our hands immediately below this line.